Good evening, everyone, those who are in India, and good morning to those who are in United States of America. And welcome to this 28th edition of the Continuing Medical Education Program being conducted by the Andhra Medical College, Visakhapatnam. I'm very glad to tell you that we have an illustrious speaker today, Dr. Todd Price, who will be speaking about the adverse events following the immunization later. And before that, I wish to thank Dr. Ram Kairam, who has been strongly supporting this program, both in terms of providing the platform for us, as well as in making in providing us the speakers who are very well acquainted with the knowledge of COVID-19, as well as the vaccination program. And as you are all aware that we are into almost the fourth week of vaccination in India, and in the phase one, it is the healthcare workers who have been selected to be vaccinated, and we have been very successful in doing so. And now we have formed at the district level. District of Visakhapatnam has got around 47 lakhs of, that means 4.7 million population, and we have about more than 40,000 healthcare workers here, and out of which more than 27,000 have been vaccinated in these 3 weeks. And we formed an AEFI team at the district level, that is the team which deals with the adverse events following the immunization, and our institute being the major teaching hospital here, this has been identified as a center for treating the adverse events following immunization. I am heading that district AEFI team here in Andhra Medical College, and the attached teaching hospital, that is the King George Hospital, has been named as the tertiary care AEFI hospital. So in these 3 weeks, we had certain experiences which we wish to share before Dr. Price come in. Dr. Price is going to deliver his lecture. So for the, sharing our experience with you all, we have the Assistant Professor of Anesthesiology, Dr. Tripti Aramelli, who will be going through certain statistics as well as these case scenarios which have been experienced in King George Hospital, that is the teaching hospital attached to Andhra Medical College. I request Dr. Tripti to go ahead and make her presentation, and after which I'm going to introduce Dr. Price. Over to you, Dr. Tripti.
One and all. And good morning, a very good morning to our guest speakers and from the US. I'm Dr. Tripti Aramelli, and today I'm going to present the AEFI cases in Visakhapatnam district during the first 3 weeks of vaccination. With immense pride, a report in Times of India trickled in the first week of February, stating that India has become the fastest country to vaccinate over 4 million people. In Visakhapatnam district itself, about 27,318 healthcare workers were vaccinated, and King George Hospital has been designated as the AEFI treatment center in our district. The total number of AEFI cases which were reported in our hospital have been 9, and they were treated by a core team consisting of a physician, a cardiologist, a neurologist, and anesthesiologist. So I would like to start presenting each of the cases. The first case which had come to us was a 40-year-old female, and she was vaccinated with Covishield on the first, that is 16th of January. Within 40 to 50 minutes of vaccination, she developed breathlessness, chest discomfort, and palpitations. At the vaccination site, she was given injection hydrocortisone and IM adrenaline, and then she was referred to the AEFI center. On receiving her at the AEFI center, the vitals were as follows. The temperature was normal, her pulse read about 90 beats per minute, and her blood pressure was also within normal limits, that is 120 by 80 millimeters of mercury. On digging the history of the patient, it was known that she was a known case of depression, and the depression was treated 2 years ago. We treated her with reassurance, and tab clonazepam was given to her along with tab paroxetine. The patient was normal and she was discharged on the 18th of January. So this was the first case which was noted, which was treated. The second case was a 34-year-old male patient, and he was vaccinated on the 27th of January. Around 6 hours after vaccination, he developed giddiness with epigastric discomfort, myalgia, and due to which he could not sleep the very night. The next day, he was referred to the AEFI center, and a diagnosis of post-vaccination anxiety neurosis was made. He was also reassured and prescribed clonazepam along with supportive treatment of pantoprazole and tab paracetamol. He was discharged the next day after his vitals were stable. The third case was a 30-year-old female patient who was vaccinated on the 16th of January. Approximately 5 days after vaccination, she had developed a mild fever of 99 degrees Fahrenheit and she had giddiness. She went to the local PHC where she was treated with symptomatically with paracetamol and pantoprazole. And for further precautions, she was referred to AEFI center in KGH. On receiving her at the center on examination, there were no signs of inflammation at the injection site, which is what we usually check for. And for her, also a diagnosis of post-vaccination anxiety neurosis was made. She was also reassured and prescribed clonazepam and discharged after 48 hours after seeming fit. The fourth case, which was received at our center, was a 30-year-old female who was vaccinated on the 22nd of January. 5 days later, she developed fever, diarrhea, nausea, and mild shortness of breath. She was referred to AEFI center at KGH, and a diagnosis of post-vaccination acute febrile illness was made after routine investigations. She was prescribed ofloxacin for diarrhea, and symptomatically she was treated with paracetamol, levocitrazine, pantoprazole, and B-complex. She seemed to be fit after 48 hours and she was discharged then. The fifth case was a 53-year-old female who was vaccinated on the 20th of January. About approximately 20 minutes after vaccination, she complained of breathlessness, and immediately she was referred to KGH. On examination, her blood pressure recordings were about 180 by 100 millimeters of diastolic mercury. She had no history of any comorbidities, and a diagnosis of anxiety neurosis was made. She was also reassured and tab clonazepam was given. The very next day, she seemed to be completely normal and discharged. The sixth case was a 25-year-old female who was vaccinated on the 23rd of January. About a week later, she complained of fever, nausea, and headache. After routine investigations and examination by our core team, a diagnosis of post-COVID vaccination acute febrile illness was made. She was prescribed doxycycline 100 milligrams BD twice daily as the antibiotic, and she was also given supportive treatment with paracetamol, pantoprazole, and ondansetron. She was normal within 2 days and she was discharged on the 3rd of February. The seventh case was a female of 23 years old, and she was vaccinated on the 28th of January. 3 days later, she developed breathlessness and also dry cough. On examination and digging her history, she gave a history of dust allergy and with chronic sinusitis, and she was a known case of, she was an asthmatic since childhood. On examination, bilateral wheeze was noticed, and after diagnosis of post-vaccination AEFI, that is acute attack of asthma, was made. She was treated with injection hydrocortisone 100 milligrams IV and salbutamol nebulizations. She was also prescribed levocetirizine and alprazolam to relieve her anxiety. And the eighth case was a 29-year-old female who received Covishield vaccination, and within 4 hours of vaccination, she developed breathlessness. She was also diagnosed with anxiety neurosis and prescribed clonazepam and pantoprazole and discharged the very next day. The ninth case and the last case which we received was a 29-year-old female who was vaccinated with Covishield on the 22nd of January. After 2 days, she complained of sore throat and giddiness. She was a known case of hypothyroidism, but she was referred to us pretty late. That is, she was referred to us on 6th, that is yesterday, for evaluation because her sore throat was still persistent. The core team diagnosed her having acute pharyngitis and she was treated with amoxiclav potassium clavionate, pantoprazole, B complex, and paracetamol. Today morning, she was perfectly fine and she was discharged. So, if we see all the cases, most of the cases which we received were young women, females under the age group of 20 to 30 years, and most of them were diagnosed with anxiety neurosis. 2 of them had acute febrile illness, one had acute pharyngitis, and the other acute attack of asthma. Fortunately, all the 9 patients recovered well with stable vitals and they were discharged from the hospital. So, this is the summary of the 9 AEFI cases that were that had come to the notice in Visakhapatnam district. Thank you so much.
Yeah. Thank you. And thank you, Dr. Tripti. As you all must have noticed, so we had about 9 cases out of 27,000 vaccinations reported to the AEFI and King George Hospital. The minor ailments like the fever, myalgia, tingling, headache, and other ailments have been treated at the vaccination sites themselves. People who would require hospitalization or an expert treatment only have been referred. And as you must have noticed here, all of them were women, young women in their 20s and 30s. Then we'll have a discussion on this towards the end of this program after Dr. Price speaks, so that we will give him adequate time. And Dr. Tripti will be available to us to answer any questions. Before Dr. Price speaks, I wish to introduce him and I wish to thank him very profusely. Before I introduce Dr. Price, I recognize the presence of Dr. Bhagavatul Ramakrishna, who is a specialist in infectious diseases, who was on this forum earlier explaining us the different types of vaccines. And I thank him very much for joining this morning. And also, I request him to be logged in so that he can answer the questions towards the end if there are any queries from the audience. Thank you very much, Dr. Bhagavatula. Dr. Todd Price is an illustrious speaker and he is an infectious diseases specialist. And Dr. Price has been in the medical practice in the infectious diseases field since 1988. He has a lot of commitment towards and a missionary zeal, and he conducts various medical camps throughout the world, including India. And he's very humanitarian and involved in various humanitarian activities. He graduated from the Oral Roberts University School of Medicine in 1983, and later he did his internal medicine residency from the University of California at Los Angeles in 1986. Later, he did his subspecialty in the infectious diseases from Baylor College of Medicine in Houston, Texas in 1988. And from then onwards, he has been practicing and he's an attending. And I am very glad that he has agreed to share his experiences and his expertise in the field of adverse events following immunization, the immunization and the infectious diseases. I request Dr. Price to go ahead and make his presentation.
Well, thank you very much for allowing me to be with you. It's always a pleasure talking to professionals from all over the world and sharing our experiences together. So I first like to First like to talk about the adverse reactions in any vaccine. And then I'd like to talk about how the COVID vaccine, the mRNA vaccines have been produced. Overview of allergic reactions associated with vaccines, including the COVID vaccine. Under most instances, all vaccines used in national immunization programs are safe and effective. However, no vaccine is completely risk-free, and adverse events can occasionally result after immunization. Adverse events can range from minor side effects, as we heard, to more severe reactions. They can be a cause of public health concerns about the vaccine safety, which no one needs. Questions that we need to answer is what caused the reaction? What was it related to the vaccine, or was it the way it was administered, or was it unrelated? And also, are the reactions minor or severe? There are different classifications of adverse events following immunization. They're grouped in 5 categories: vaccine product related, vaccine quality defect related, immunization error related reaction, immunization anxiety related reaction, and coincidental events. Serious events result in death. They are life-threatening, requires inpatient hospitalization or prolonged or existing hospitalization, results in persistent or significant disability or incapacity, is a congenital causes a congenital anomaly or birth defect, requires intervention to prevent permanent impairment or damage. Serious events is used to describe the intensity of a specific event, such as mild, moderate, or severe. The event itself, however, may be of relatively minor medical significance. Fever is a common, relatively minor medical event. This has been described in various ways. The European Medicines Agency publication essentially describes fatal or life-threatening adverse reactions, serious unexpected adverse reactions. The AEFI include neuritis, convulsions, anaphylaxis, as well as others. Vaccine reactions is an individual response to the properties of the vaccine, even when the vaccine has been prepared, handled, and administered correctly. These can be reclassified into groups. There are minor reactions and severe reactions. Minor usually occur within a few hours, resolved after a short period of time, usually includes local, but can also be systemic. Severe reactions usually do not result in long-term problems. They can be disabling, however, are rarely life-threatening, include seizures, allergic reactions caused by the body's reaction to a particular component in the vaccine. There's been many vaccines, in fact, most vaccines that have had minor vaccine reactions. Some of the common ones that we use in children are described here. Severe vaccine reactions can also be described from these very same vaccinations, but they're relatively rare. An example is polio, the oral polio. As has been described, oral polio vaccine can sometimes cause paralysis, either in the recipient of the vaccine or someone in the recipient's family, such as patients that may be undergoing chemotherapy. Not all severe reactions are serious reactions. This is the difference between serious and severe reactions, as you can see. There are also immunization error-related reactions, which result from errors in vaccine preparation, handling, storage, or administration. They are preventable and detract from the overall benefit of the immunization program. Immunization errors can result in a cluster of events defined as 2 or more cases of the same adverse event related in time, place, or vaccine administered. There are also immunization-related anxiety reactions, such as fainting, hyperventilation, vomiting, and even convulsions. There are also coincidental events which occur after a vaccination has been given but are not caused by the vaccine or its administration. Mass vaccination campaigns are very important because it involves administration of vaccine doses to a large population over a short period of time. But as a result, adverse events may be more noticeable to staff and to the public. Campaign for mass vaccination is an opportunity to strengthen or establish surveillance. Adverse events and their effects during a campaign can be minimized by proper planning aimed to reduce immunization efforts. Errors. Components of such planning include thorough training of staff, monitoring and responding to reactions, engaging the community, among others. The rates of adverse reactions are part of the work of health professionals. It's useful to compare or report these reactions to each practitioner's jurisdiction with expected adverse events in the unvaccinated versus the vaccinated versus the unvaccinated individuals. They help to strengthen the capacity to introduce vaccines in member states. These cover the routine childhood vaccinations. There is importance to compare observed with expected rates. If the background rate of a particular adverse event is not known in a community, as is often the case, you will need to compare the observed rate to your population with the expected rate, which is published by the vaccine regulatory authorities. Other factors to consider when comparing rates of AEFIs include confounding factors as anything that can coincidentally associate with an event. This may be misleading. These include vaccine doses. Adverse events may be defined in case definitions, as we've heard. There are surveillance methods and background rate. So this is background as far as adverse reactions with vaccines. Now, to proceed specifically to the vaccine that we are utilizing in the United States. So the SARS-CoV-2 vaccine that we use in the United States has some background. The overview of vaccine development for any vaccine includes preclinical, which is the vaccine utilized in small animals to determine immunogenicity and toxicity. Then there's phase 1, a small number of humans, determine safety, how it develops immunity, and also determines the dose. Then it goes on to phase 2, which is more humans, determine safety, and also determine how this large number of humans develop immunity. And then phase 3, which is vaccine versus placebo. Vaccine efficacy is determined by reduction in specific disease incidence among those who receive the vaccine versus those who receive the control product. This is calculated by attack rate in the unvaccinated minus the attack rate in the vaccinated divided by the attack rate in the unvaccinated times 100. The SARS-CoV-2 vaccine pre-development benefited from the previous COVID coronavirus outbreaks, SARS-CoV-1 in China and MERS-CoV in the Middle East. Both diseases vaccine development was involved in both diseases. There were preclinical studies in both. There were phase 1 trials in both. But when the diseases essentially disappeared after a few years, that development stopped. However, in development of the CoV-2 vaccine, we benefited from the work that had already been done. The antigenic target for these vaccines was the large surface spike protein. This protein attaches to the receptor on the host cell and induces membrane fusion. There was vaccine-enhanced disease in animal studies, which causes eosinophilic pneumonia, but this was not a problem in preclinical and phase 1, 2, and 3 trials in humans. There are various vaccine platforms. I believe the vaccine that's used in India is a replication and competent vector vaccine. But there are inactive vaccines where the virus is chemically inactivated. There are live attenuated vaccines, which the virus or pathogen is weakened. There are recombinant protein vaccines where viral proteins only are used. And then the vector vaccines. There are DNA vaccines in which a DNA plasmid is inserted into the cell, targets a gene, which targets a protein, in this case, the spike protein. And then finally, the RNA vaccines, whereas RNA is translated into the target protein. The SARS-CoV-2 RNA vaccine is a new technology that has not been used before. The RNA is translated to the target protein to develop an immune response. The mRNA remains in the cell cytoplasm. Thus, the mRNA does not interact or enter the recipient's DNA. It's produced in vitro and must be stored at low temperatures. So, the two RNA vaccines are the Pfizer vaccine and Moderna vaccine. The Pfizer vaccine is approved for those 16 years and older, 0.3 milliliters, 3 weeks apart, 2 doses. The Moderna vaccine is for those 18 years or older, 0.5 milliliters per dose, 4 weeks apart, 2 vaccines. Both approach approximately 95% protection. So regarding these RNA vaccines, there are special populations that need to be considered. Any patient who has had COVID, once recovered from the acute infection, can receive the vaccine. However, they must have met criteria for discontinuation of quarantine and isolation. Those who were treated with monoclonal or convalescent plasma must wait 90 days. And because there's not much vaccine available right now, we prefer that all others who have not received monoclonal or convalescent plasma should also delay for 90 days post-infection, since they have developed some immunity, which lasts for a short period of time. Another special population is those who are pregnant or those who are breastfeeding. Safety has not been established, but pregnancy is not a contraindication to vaccination. The decision should be made by the healthcare provider and the patient, dependent upon the patient's risk and exposure. The final population that needs to be considered, other than the normal population, is the immunocompromised host. These are those who are cancer undergoing chemotherapy. They are able to receive the vaccination, but the efficacy and the ability for them to develop immunity is not clear. But in most cases, the benefit of using a vaccine far outweighs the risk. So SARS-CoV-2 RNA vaccines have contraindications and precautions. Those who've had severe allergic reactions to previous dose should be considered not to receive the second dose, of course. Severe allergic reactions to components of the vaccine, including polyethylene glycol, should also be considered. All patients should be monitored, of course, for 15 minutes. Anaphylaxis to any previous vaccine in a patient, these patients should be monitored for 30 minutes. Finally, the SARS-CoV-2 RNA vaccine side effects. We're just having some experience with it. Seems like we have approximately 20 million have been vaccinated in the United States. That there may be a little more, maybe a little bit less. But it's been found that anaphylaxis occurs in 2.8 to 5 events per million doses. There are, of course, local reactions and facial swelling. So that concludes my presentation. I'm willing to take any questions now or proceed to the next presenter.
Yeah, yeah. Thank you very much, Dr. for a very crisp and clear presentation, particularly referring to the AEFIs. I have certain questions before we go forward. I shall be very glad if you can answer them. So you must have seen the presentation made earlier of having about 9 cases out of 27,000 of immunizations that we had in the first phase. What do you think is the rate at which the AEs are recognized here and those who are requiring hospitalization or attention? And how is it different in the United States and other countries with regards to the frequency of these AEFIs?
I'm not sure how it differs in the United States. In my experience, I've practiced and I've been in about 40 countries. And I do know, in my experience, patients in the United States complain more than anywhere else. So I do believe there's going to be more side effects reported in the United States. Many United States are on the web and looking at the news, looking at social media, and sometimes that's not the best thing to do. And it's a little exaggerated, both the news media and also social media, of the incidents. And so the public health officials here must be very vigilant and aggressive in communicating the correct incidents and to allay the fears of the public.
Yeah, thank you. And have you found any difference in the AEFIs of different vaccines? Now that you have the Moderna and Pfizer, we have the Covishield and Covaxin in India. Has it come to your notice that the AEFIs are different when different vaccines are being used?
It may be too early. I'm sorry.
Yeah.
Yeah, it may be too early to tell, but theoretically, because of the way that this vaccine was developed and made, where the mRNA enters the cytoplasm of the cell and does not enter into the host DNA or nucleus, theoretically, the side effects should be less, but that's all theoretic. It's also not, there's a lot of unknowns. It's not known how long the immunogenicity will persist. It's not known if boosters are going to be necessary. I think time will tell. what happens in regard to the incidence of side effects, as well as whether the vaccine is long lasting.
Yeah. In your experience, you must have seen these, you have enumerated the different vaccination programs. In your experience, how will you rate the AEFIs following COVID vaccination compared to previous vaccinations in the scale of 1 to 100? Earlier, Dr. Karam was referring to this, and he said that he would place it around 3 from 1 to 100. And many of the vaccinations earlier had worse AEFIs compared to what we have today against the COVID-19. What's your experience? How would you rate the AEFIs following this COVID vaccination compared to what the vaccinations earlier on?
My experience, I have not really seen that many side effects to the vaccine. I have limited exposure in my facility. Probably about 80,000 individuals have been vaccinated, and this not just the facility here, but here in the Houston area. So I've actually not seen any patients with side effects. Admittedly, I would be towards the end of who would see, because the primary care physicians see them first. I've received calls, but they've most been local. So it appears to be less incidence of side effects as compared to the normal vaccinations.
And Dr. Ravi Sharma has put a question here. Would a morbid obesity be a contributory factor for the severe AEFI? And it seems there was a popular case in America, in Virginia, a woman who died who was weighing about 500 lbs. And he wants to know whether high BMI in patients with high BMI are at an increased risk. Are you there, Dr. Price? Am I audible?
I'm sorry. I missed the question. I'm sorry.
Dr. Ravi Sharma has put in the chat box. He said that would the high BMI in patients has an increased risk in developing the AEFIs. That is one. He's referring to a popular case. A woman died of several hours after the Pfizer after receiving the Pfizer vaccine, and she was weighing about 500 lbs. He says that would this high BMI has any relation to the AEFIs?
I can't really. I don't know. That's a simple question. I don't know yet at this point. We're in a new vaccine. We're experiencing things every day, but as far as side effects with vaccinations, it seems, from my experience, it's very minimal.
Yes.
But Dr. Sudhakar,
Yes.
if I may,
Yes.
this is a good example. Out of the slides that Dr. Price presented, there was one that many people may not pay long attention because it looks a little complicated. That is to calculate the expected rate. In other words, you have to understand the base rate of what events could occur in the life of such an individual. So when you have large populations being given vaccine, there's a body of data available. How frequently could heart attacks or asthma attacks occur in that population anyway, unrelated to the vaccine? So to answer the question regarding the 500-pound lady dying, it would be very difficult to attribute that to the vaccine because she had reasons to die by virtue of her coexisting risk factors. So it would be best. I love the way Dr. Price answered. He repeated twice. We don't know. But people, instead of saying we don't know, the way the news is coming, well, could obesity be a risk factor? Now, your data is very interesting to me. Your assistant professor presented 9 cases. 7 are anxiety reactions. It's amazing how frequent that is. It would not be a surprise if translated to large numbers. So I'm just making a comment that the obese woman or somebody else with a pre-existing risk factor might fall into the base rate, the rate that would have happened in the general population anyway. It will be very difficult to say that it is due to the vaccine. Dr. Price should agree.
I agree. The anxiety reactions seem to be the most common, at least here in the United States. So it's correct. What would happen without the vaccine? It's kind of difficult to determine in this obese woman. So, so the basal rate, what I was saying is that we don't really know with the vaccines that we're using the expected rate with the vaccine per se. But because we have social media and the news organization that will jump on any person that has a side effect, that's going to be highly visible in the news cycle.
Okay, thank you.
Yeah, I think that has been taken care of largely in this district. You must have noticed that we had 9 individuals who required attention out of 27,000. That comes 3,000, 1 in 3,000. I think that is quite reasonable. And here, a question is that whether the skeptics, people who are not very, enthusiastic in getting the vaccination done, may fall prey to this particular anxiety neurosis. Probably a history of their whether they were willing to vaccinated in the first place without any reservations may play an important role here. Anyway, protocol has been made right in the beginning at these vaccination sites, wherein they'll be asked the question not only with their general condition of the health, but also whether they are to make them sit comfortably and see that they are all, when they are being vaccinated, they are in the maximum zone of comfort. I think people who are very skeptical or who are not very sure whether they would like to get vaccinated, or people who are fearsome, are the ones maybe who are going to have this anxiety more than people who usually expect that there would not be much adverse reactions. So from the media point of view, we have taken a lot of initiatives to tell the public, first by vaccinating ourselves first, and number 2 by telling people that the adverse events are very minimal and they are far less compared to what we see in the general public with other ailments. They might be having the general ailments more often than the adverse events. So with that, we can dispel the misconceptions to a large extent in the district of Visakhapatnam.
Can I add one?
Yeah, Dr. Krishna, please.
You know, at least hello. In India, I don't know about anti-vaxxers, but maybe some hesitation to take the new vaccine. But in highly developed countries like England, United States, we have anti-vaxxers and their propaganda. Luckily, there are only a few thousand people, but enough to get on the social media and cause a lot of unnecessary panic. I think it is very early to tell any major side effects will occur with these vaccines. They're new, but the chances are very small. You know, to me, it looks like talking to so many people who got vaccinated, the Side effects very minimal. I'm sorry, there's some kind of interference. So anyway, the very minimal side effects like pain at the site of injections. Some women complained of weakness, fatigue for a day. That's about it. Most of the side effects so far I have noticed by talking to people, not in thousands, but maybe a few hundred, has been very minimal. And as Dr. Price said, we don't know the long-term thing, but at present, what else we have? We have no other treatment, and the vaccination is only our way out of this pandemic. And I think doctors can educate by telling common people, lay people, about our history, as I spoke to you before about experience with the polio vaccine, smallpox vaccine, how we could eliminate the diseases. I think every doctor should educate himself about vaccines and side effects and try to educate people.
I like to agree with that wholeheartedly. My experience also is in seeing patients with COVID, and I've seen maybe close to 1,000 patients. And all you have to do is see one serious infection and know that we have to do something. And this is our best way out of this pandemic, the vaccination. And I agree that the anti-vaxxers are in low numbers, but they like to talk a lot. We just need to be very forceful and explain to, as I do to all my patients, everyone asks, that we need to get the vaccine. It was also our opportunity as healthcare providers to take the vaccine first, to be an example, and to explain to our patients and the community that we had very minimal, if any, side effects. I took the Pfizer vaccine. I had essentially no side effects. So I try to advertise that wherever I go. I'm sorry I might have to leave at this point to another engagement, but I really appreciate the opportunity and being with you, and hope maybe I can be with you again at some future date.
Thank you.
Yes, thank you very much. And we appreciate your involvement and your scholarly lecture. Thank you very much.
Thank you.
Dr. Price, thank you very much. Kairam.
Thank you.
Dr. Kairam,
Yeah.
Doctor?
Isukapalli has a question. She has raised her hand. Dr. Vani, please go ahead and ask your question.
Yes, sir. Good evening, sir. So this may be answered by anyone who is fluent in the adverse events following immunization. Sir, just now actually I got a call from Srikakulam that one lady from Palasa who got vaccinated day before yesterday, that is on 5th at 11:30 a.m. was found dead today morning 3 a.m. And then she was brought to Srikakulam Government General Hospital, and then the body was postmortem, and then the report of the postmortem was is awaiting. And meanwhile, the district authorities and the AFI team has convened an emergency meeting, which is going on now. So I would like to ask any of the experts here. So what factors would you take into account in such a case? So this woman is a 29-year-old female with no comorbidities, so got vaccinated and had a sudden collapse and died within 48 hours. So what factors from the history side and on the examination side or from the postmortem will tell us if it is really a vaccination death or some other cause? So this is my question, sir.
Yeah. Vani, I would request Dr. Sridhar Chilumuri to comment on this. Basically, as to what constitutes an AEFI death is your question. And,
yes, sir.
You have given a clinical scenario, and without knowing the postmortem, perhaps it would be difficult. However, Dr. Sridhar Chilumuri will be commenting on that.
Yeah. Thank you. I think it's a tough one to explain, but I think I would start the allergies in majority of them, you will see them in the first 1 hour, but they're not exclusive in 1 hour. You could get a delayed response up to 6 hours after that. You could get anaphylaxis. So not knowing, maybe she had some kind of allergies that we didn't know of, particularly which may have actually shown in the first few hours. So sometimes what you're watching for, you look at the injection site and you will see hyperemia or some kind of pruritic lesion. And then when it spreads to 2 areas, so not just your hand, but now in your neck or on the other side of the body, now you have a problem on your hand. You may not have acute anaphylaxis at that time, but that patient is more likely to develop a delayed allergy, and you need to watch them. This has happened in the United States where somebody developed anaphylaxis several hours after. So they were watched for 15 minutes, released, and then on their way home, they developed anaphylaxis. So being young and she not having any other medical problems, I would still suspect that this was delayed anaphylaxis. So on postmortem, I'm looking for evidence of angioneurotic edema, how her airway was, and if the airway was particularly compromised. It would have been good if he had her blood, and a serum tryptase level would be really useful. If it's elevated, that would definitely show that mast cells have degranulated, and that must have caused anaphylaxis. Here and there, we do see arrhythmias on a regular basis. At the earlier speaker point, in your own experience, you see these anxiety episodes. Some of them are accompanied by PVCs and even atrial fibrillation or supraventricular tachycardia. Just assume if she had some kind of mitral valve disease and you triggered an SVT, that could cause a sudden cardiac death. So in the autopsy, I would also look at if she had an underlying mitral or any kind of valvular heart disease that was unknown, and an arrhythmia could easily cause sudden cardiac death. Pulmonary embolism was reported with flu vaccines, but within 6 hours is very unusual. Usually they develop in a few days after flu vaccines. Here and there we've seen that. We haven't seen that at all with COVID vaccines as yet. So my bet would be on anaphylaxis. The autopsy should focus on the airway. If you have blood, look for tryptase and maybe complement levels. And finally, look at her heart and see if there's any abnormalities that were not detected previously. That's my comment.
Yeah, thank you very much, sir. And can Suresh Anne, Dr. Suresh Anne is on, he's there logged in. And may I request Dr. Suresh Anne to have his comment on this. Unfortunately, the serum tryptase values are not being estimated in our setup. So probably in the autopsy, the airway has to be concentrated upon, as well as the cardiac part of it. Probably Dr. Vani will tell the person who is doing autopsy over there, I mean, autopsy must have been finished, to concentrate on these 2 aspects as far as the findings are. May I ask Dr. to give his viewpoint on this?
Thank you, Dr. Sudhakar. I agree what Dr. Chidamuri mentioned. Definitely, there are within 6 hours is a period that you can develop anaphylactic reactions. Most commonly we see that with food allergies, because the food antigens in the stomach. With other allergens, we see usually immediately within half an hour to at the most 1 hour. At 6 hours, it's possible, especially with the vaccines and other drugs. I agree what Dr. Chidamuri is saying, especially with a young woman that's having 6 hours collapsing. It would have been really good to get the blood for these kind of patients to see the tryptase levels. That is very, very, very helpful. So, other than that, there is nothing much we can do in this condition. Dr. Chidamuri was explained very well, and this is probably maybe an anaphylactic reaction. Also, I want to mention one thing. You may not see an anaphylactic reaction to angioedema. I mean, just that will help if you see the angioedema. Most important factor that finding that you can concentrate as any patient that develop pruritus or hives other than the site of the injection. It's a very important sign. Initially, you can recognize impending anaphylactic reaction. We commonly see that they start having the arterial rash under the axilla. I want to make sure everybody, if he is suspecting anaphylactic reaction, or if you're suspecting the patient is complaining itching in the axilla or some other place, make sure address it that time. Giving the epinephrine, Benadryl, etc., will prevent the major attacks. So I think that's the maximum that I can add to this patient. And in now it's a delayed. I don't know whether the blood test can show any tryptase levels elevated. It's almost now more than 12 hours. So I'm not sure because tryptase can be stable up to 12 hours. You can find traces, but after that, it's not that significant.
I feel it's definitely a delayed reaction because the average duration of the time is only about 0 to 214 minutes for an immediate anaphylaxis. That's what in the study says.
I can see a question in the chat box by Dr. Saroj referring to a case in Guntur. We tried to gather some information before coming to this particular program about that death in Guntur. And it has been mentioned after the postmortem that it is the brain infarction which has killed her. She's a 48-year-old lady, and it's a couple of days after the vaccination. So they did not find any signs relating to the anaphylaxis in the postmortem. It is the infarction of the brain that's what has been conveyed to us. So, Sridhar, what's your that?
So first thing is that we cannot ignore the fact that we're still in a pandemic. So, she could still have COVID, the woman the lady who died in Guntur, unfortunately. A lot of people think after the first dose, they are protected. They are not protected. We've seen many patients get COVID after the first dose. Indeed, I don't think it's 91% or 94% effective either. We have now reached a phase. We have a number of people who completed 4 weeks now, as of today, 4 weeks after the second dose of vaccine and have gotten infected. So I think if you assume that it protects you 100%, it's wrong. It certainly does not protect after one dose altogether. And so we still have to worry that they may have gotten COVID just because they're vaccinated. It just has to be maybe coincidentally around that time, she probably had COVID also. The fact that she's a relatively young person with an infarct, for me, I would do COVID tests on her even post-mortem and see if she had COVID. I can't think of the vaccine. And which vaccine is this? This is the AstraZeneca one, I'm assuming, or yeah?
Yes.
We have not seen with the mRNA vaccines we use in the United States anybody developing acute strokes with it at all. There is no thromboembolic phenomenon reported with it so far. I think United States has given 30 million doses now. This signal has not shown up. So in her case, I would worry if she had COVID and we missed that.
Yeah.
Cool. Can I have a question?
Yeah.
Murray?
Yeah.
Go ahead.
Could this be a mutant away? Do you know it is a genetic mutant like we saw in England or in Brazil or in South Africa? What about, could it be a variant that could have given the disease and or in America, as you mentioned, many people are getting infections. How many of them have a genetic variant or a mutation, one of these 3 mutations we are seeing in the P or in the spike protein?
I think it's an important thing to consider. United States may be seeing a surge of UK strains now. we don't necessarily do the strains regularly. I think the state health lab does a few randomly. So they said UK strain is in New York State now. As you know, it could escape vaccination. There's indirect signal that UK strain is here. And the way to observe that is the high attack rates in a household. So if you recall last year, in the household attack rate, so if one person in a household got infected, the remaining people in that household being infected was around 20%. Now in New York City, we're seeing 80%. So that high attack rate suggests that UK strain is maybe the prevalent one. We don't routinely look for it. There's no way our labs can run it. So we're waiting for the state to tell us how prevalent the UK strain is. And that's a possibility that vaccine efficacy is going down because of the altered strains.
That brings us, one, Dr. Sudhakar, if you don't mind my adding one thing.
Go ahead.
This got to be a conversation for another day. In Manaus, Brazil, they had very high instance of COVID. They thought that almost 70% of the people got infected in the first wave, and they had herd immunity. And then they had a second wave now going on. And so that is causing a big concern by the disease from P1 mutation that's going on in that country. However, it was not scientifically proven yet. Only United Kingdom is the only country that is genetic sequencing very rapidly and with a very centralized program. United States has nothing comparable to that, so we'll be always behind in finding whether any mutations are causing new disease. That said, if we truly believe that the vaccines are 70 to 95% effective, to keep up or catch up with the virus, we have to vaccinate very rapidly a large number of people, because mutations occur because we're giving virus an opportunity to mutate. That means a large population has to be infected, so then they can mutate faster. If we don't give the virus a chance to infect, the mutations will be less, and we can get over so we have to rapidly vaccinate people at this time instead of worrying about, various things. Side effects are important. We got to observe them and all that. But I still feel that we should promote vaccination programs, and hopefully the governments will do more to supply vaccine to general doctors and pharmacies, whatever.
Thank you, Dr. Krishna. Dr. Naveen has a question. Naveen, go ahead.
Sir, good morning and good evening, sir. The first part was very vividly discussed by Anish Suresh sir and Sridhar Chilamuri sir. I just want to add about that serum tryptase only. Just dismissing of cases like anxiety neurosis. We better do the serum tryptase test, because Anish Suresh sir earlier in this forum said to establish vaccine-related AEFI, you have to do serum tryptase. So unfortunately, it is not available in our setup, sir. Like the US finding, our finding is also very commonly anxiety neurosis only, sir. KGH, all the KGH cases also. The second thing is, sir, what about this mix and match new concept coming in vaccine, sir? UK people, UK scientists are floating this new concept, mix and match, about giving first dose with one vaccine and the second dose with another vaccine. Any comments, sir? Any comment? Mix and match, they are floating this new strategy concept, sir, in vaccination.
Sorry, I'm Dr. Malampalli. I'm from UK, yes, one of the consultants in anesthesia. Yeah, I can add a little bit of discussion to this. UK is currently not recommending the cross-company vaccinations as at present. They're only sticking to either AstraZeneca or Moderna.
Yeah.
So they're not recommending actually the cross-company vaccinations.
Okay.
Thank you.
Naveen garu.
Absolutely. I think we have no experience mixing and matching. In the United States, we only have mRNA vaccine. There's no theoretical advantage of mixing Moderna with Pfizer because actually the immunogen is the same. It's still the mRNA for spike protein. How you deliver it shouldn't make much of a difference. I think we should right now focus on whatever vaccine you have, give it as much as you can. That should be the goal. We'll come 6 months from now, we'll revisit and see the efficacies and transmission rates, and then we can try the other stuff. But for now, let's push the vaccine as much as we can. Certainly, some deaths here and there is going to make the public quite anxious. And that's when we have to show leadership and say, listen, this can happen. We can give them valid explanations of what might have gone wrong and push this agenda. I think we can get distracted if we start talking about, mixing, matching, and all that stuff. Once we have, let's go 6 months with this. Let's see what we have and then think about options.
Yeah.
Sridhar, to add to that. Sudhakar garu, may I?
Yeah, please.
Okay, now to Naveen's question about that the serum tryptase. Again, you don't need to do the serum tryptase on everybody. And when you have the clinical symptoms, so like the other patients that who described, they do not have the hypotension, they do not have any palpitations, they do not have any other signs. There is no reason to do the serum tryptase. When you suspect anaphylactic reaction, those are the patients that we need to serum tryptase to identify whether it is truly anaphylactic reaction or any other disease that is causing the symptoms. That is the one point. And again, Sridhar, what you mentioned about that, and I'm having a little bit difficulty about these vaccines. We are measuring the IgG antibodies. I think the most of these efficacy studies and everything is IgG antibodies. As you know, the viral immunity is mainly the T-cell immunity. Most of the patients that you see a viral infection, unless the IgG antibodies were only useful for diagnosis of whether they have an acute or old infections, but their immunity is mainly dependent on the T-cell immunity. If you look into the Pfizer study, the T-cell immunity, even after the first dose of vaccine, is persistent, 100%, and the booster dose did not affect anything on the T-cell immunity. So if you take that study, I don't know, I understand the rationale why we are vaccinating the people that have the disease and recover. They already have the T cells. They have produced T cells and they have a long-term immunity. If you go back into the MERSA study, the MERS study where they showed the T cell immunity lasts more than a year. But then the study was stopped because the MERS was closed, everything, the pandemic or the endemic was gone. So I think we are focusing more and more on IgG antibodies than doing when you said that there are some patients that you're seeing infection after the second dose. Are these severe infections? Are these patients need to be, end stage or any mortality that you're noticing? I think unless you get the population studies, you cannot tell whether these vaccines are very effective or not effective. So go ahead.
Yeah, all good points. They are good points. I think T cells do play a role. What I am telling is that we have seen infections. None of them were severe. Most of them were mild, but confirmed. So I can say definitely PCRs were positive and they had clinical symptoms. Of the few we saw, we just saw a handful now, not a lot. Two of them, I can give explanation why the vaccine may have failed. So your point about T cells is for people who have gotten infected. Let me just talk about people who did not get infected and got vaccines. I think in the chat window, somebody asked whether you can give a vaccine to people who have pancytopenia and splenomegaly. So I'll answer both with using this as the example. So if you have for whatever reason, suppressed B cell function because you've gotten medications or in that particular individual with pancytopenia, there's a likelihood that the vaccine will not work as effectively. That's what we saw in a real patient who's on a CD20 suppressor for multiple sclerosis. He gets that infusion for his MS, completely vaccinated. 3 weeks after the second dose. By the way, he was always antibody negative. And then 3 weeks after his second dose of his Pfizer vaccine, he developed COVID, PCR positive, clinical symptoms. Now you asked me were they severe, but we didn't wait for it because he has risk factors. So we gave him monoclonal antibody infusion. So we would never know if he would have become more severe or not. But I can say his inflammatory markers were high very early. That doesn't necessarily mean they'll have severe illness, but he may have developed severe. And the other ones that you pointed out who got infected after the vaccine, the good news is none of them had severe infection. So your point is well taken that, yes, there may be failures, but so far none of the failures caused death. So that's good news. I think the greater point is even if you vaccinated, continue to wear masks and maintain social distancing. I think that's the point I wanted to make about vaccine efficacy.
Excellent. That's a very good point, Dr. Chalamuri. In spite of vaccination, we should follow safe distance, wear masks, wash hands. It's important not only because there will be mutations of the virus, a different mutation can cause infection in a particular vaccinated person. And for now, until we know more about the vaccine efficacy, everybody should follow same precautions, if not more. The other thing is, none of the autoimmune patients with autoimmune diseases or MS, in Italian studies showed initial big wave, first wave they got, that they were not that much more susceptible to severe disease or their mortality is any higher than general population, which is good to know. But again, they're immunocompromised and they have some, as you said, they're splenic patients or patients without platelets. They're at higher risk. Probably they should get immunotherapy, passive immunotherapy, but again, that's a questionable thing right now. That's all I wanted to say. I'm sorry.
Yeah, Dr. Srinivas Jonnala, you have a point to make. Please go ahead.
Yeah, I was just saying, I got both Pfizer 1 and 2, and I know Dr. Price said he had no side effects, but in mine and a lot of my colleagues' experience, diffuse myalgias from head to toe were there for about 24 hours, and then they all resolved. So I just wanted to add that the myalgias were quite bothersome, but it's what it is,
Yeah, Dr. Ram Kairam has a point to make.
Your mic is muted, Ram.
My comment follows what Dr. Anne said. He was still talking about monoclonal antibodies, how these vaccines would work, what it does. But if you were to stick to AEFI, I want to make one point. There's one difficult slide that Dr. Price showed that comes from the WHO about being able to calculate base rate of illness, death, heart attacks, thrombosis, etc., on top of what could be caused by the vaccine. By the time 31 million people have been vaccinated in the United States, you would want to know whether the so-called reported adverse events are in excess of base rate for those. Without knowing that, it is going to be difficult to attribute. And I think today what I learned was, out of the 9 cases, 7 were anxiety. The other two did not have severe enough disease. So you could actually conclude that after 20 or 30,000 vaccinations, Vizag did not experience, serious reactions. That would be the take-home point, because I am very saddened to see there is still tremendous amount of skepticism and fear about the vaccine. So I wanted to make a point regarding base rate of these conditions. And for example, Dr. Sharma posted a comment regarding Hank Aaron's death. Hank Aaron was 84 or 88 years old. He could have died of so many other conditions, but to prove that he died because of a complication of vaccination is a long stretch. So every opportunity we get, we must ask for, how much reasonable attempt has been made to exclude another cause of death. Otherwise, it'll get into the news.
So, Sudhakar, let me answer one of the chat questions by Dr. Rohini. Can you give, if somebody has a strong allergy, can you give the vaccine? So, Suresh, maybe you could join on this one. So, I'd like to know what the allergy is, because you want to make sure there's not a strong allergy to components of the vaccine. We have to, each manufacturer will give you the entire breakdown of the vaccine, and AstraZeneca also will show you what the components of the vaccine is. If we know the person is allergic, has a strong allergy to one of the components, then that would be a relative contraindication. But if no known allergy to any of the components of the vaccine, I think we can give it to her. I would watch her not for 15 minutes, but full 30 minutes. And if there's rash developing of any kind beyond the site of the injection, I would give her epi as soon as we can. Suresh, what do you think is the best way you would manage that?
No, Sridhar, you're right. I think most of the allergies that people are complaining about is, okay, I got dust allergy, I got a cat allergy, so can I take it? I have asthma because of the allergic reaction, can I take it? All these allergens are not contraindicated. I have treated many of my patients that have, at least 50% of my patients are allergy patients. They're all vaccinated without any problem. It's not a contraindication. Again, the components, the only component until now that recognized that does cause anaphylactic reaction probably is polyethylene glycol. The PEG is the only one that reported that possibly related to the anaphylactic reaction in Moderna vaccine, if I'm not wrong. And
AstraZeneca has that? I thought AstraZeneca has no PEG in it. Does it?
No, AstraZeneca has no PEG in it. It's mainly the Moderna and RNA vaccines that has it because of the stabilization to make it the stable RNA. So I'm not recommending any patients that even have multiple drug allergies. They make sure that they're vaccinated. Only thing that I strongly recommend, as Sridhar suggested, is make sure that they stay there, if not half an hour, even if really suspicious, maybe 1 hour, that's not a problem. Let's make sure that they get a facility where all the other equipment available for resuscitation, rather than getting on some primary care where there is no facilities. That's the only recommendation, but most of the allergies that we're talking about are safe for them. If they can get the vaccine, no problem.
Is psoriasis a contraindication?
No, it's not. No, it's not. You can give it to patients with psoriasis. Yes.
And Sridhar, if you...
Sorry.
Go ahead.
One question to the forum. Sorry if I missed it because I joined late. When do you recommend for a person who has already got the COVID and he has recovered from the COVID? What is the protocol says in US?
90 days. So in the US, it's 9. So this is how I would approach it. I would get a serum antibody just to be sure that the person has or no antibody, because some people may not produce antibodies or produce antibodies, which is very transient. It stays for about 2 weeks and goes away. It's not clear if they're more susceptible because of the point Suresh pointed out about the T cell function. But ideally, the CDC currently states 90 days if you got infected. So do not give it, you don't need it before 90 days. It's not clear if you need it even after that, but at least 90 days if you got infected.
Thank you.
Hello. I agree, Sridhar. I think, Sridhar, just to add to that, is also, I remember that you saying that you didn't have the antibodies after the first vaccine. What about the second vaccine, after the booster dose? Did you get any antibodies?
It's sent out, so I'll know next week.
Right. So the reason I'm asking, the reason I'm asking is I did not develop any antibodies after the disease or after the vaccination, the first dose. The second dose I just got last week, so I'll see whether in 3 weeks whether I get it. That is one of the reasons that I looked into the whole literature of whether the antibodies are really essential, or is it the one that is chasing a different aspect? So that was the main reason that when I look into the influenza vaccination, Sridhar, if you in the whole United States, the deaths, 99% of the deaths from influenza happened those who were not vaccinated. Yeah. So that is almost the vaccine, one dose we give influenza vaccination most of the people. So even if you take the data from there, my feeling is I think we are wasting the vaccines by giving the booster dose, and we're wasting the vaccine for giving the patients who already has the disease.
You probably are correct. Currently, because we don't know who's positive and who's not negative, the country decided just let's give it to everyone and worry about it later. But I think you may, one dose is enough, I think, for people who already got vaccinated and have antibodies. Yeah.
Yeah. Sudhakar, can I ask one question?
Yes, sir. I'm actually going to ask your question from the chat box. You already put in the chat box. Go ahead and ask the question, sir.
To all the expert panel here, Dr. Subramanian, the President of Indian Medical Association Untitled Chapter. The government of India has started the COVID vaccination with Covishield and Covaxin. The first phase is nearing completion. The doubt among some of the medical professionals is because of some of the articles published by the Oxford technical team that the second dose, if it is delayed more than the 28 days, up to that 12 weeks, the response and the booster and immunogenicity will be more. But the government of India, the health ministry, has given a protocol that the second dose will be given after 28 days. So what is the opinion? Is the 28 days second dose is the ideal period, or we should prolong it for a longer period to get the greater immunogenicity? Thank you.
To be honest, I have no experience with the AstraZeneca vaccine. We only use Moderna and Pfizer, their mRNA vaccine. We are allowed to go 4 days beyond the stipulated date. So if it's Pfizer, we can go up to 32 days or give it 4 days earlier. And the same with Moderna, with Moderna 32 days, or with Pfizer, we can go up to 24 days. So we have no experience with AstraZeneca at all, so I can't comment on it. Suresh, you have, or somebody from UK is here, maybe they can comment on what the experience is.
Actually, this is what is been stipulated actually. Currently, they are still again going with same 28-day cycle in UK also, but because they are now covering the first dose that's rolling out now in UK, so they are actually delaying. They're thinking of delaying as per the Oxford recommendation, which is true actually. So they are currently thinking in that view as well. Currently, it's going only at the first dose. You're right.
Yeah.
Ram, you have a point. Ram Mohan.
I was going to responding to Dr. Subramanian's question. The AstraZeneca is actually studying that. It's not done yet. I think it's important to understand until they themselves release this data regarding delaying the second dose, we don't have much to say. That's why I think sometimes the news travels too fast. We have to wait for AstraZeneca company itself to say what is the impact of delaying the second dose.
Can I add one thing, Ramon?
Yes.
Yeah, Dr. Krishna, go ahead.
You know, a lot of these are arbitrary. You know, a pharmacy or a drug company studies how long you give a antibiotic, or, you know, we human beings, we set a date like 7 days, 4 weeks, 3 weeks, etc. If we just take a random point and give the booster doses, what happens if you take hepatitis B, you miss second dose, well, then you go there to doctor, and not in a month later, 2 months, 3 months later, what do? They give you a shot then, and 6 months later, they give you the third one. So missing for a few weeks or a month of second dose booster probably won't have that much effect. However, we are again talking about a different type of vaccination. This is the first time we have respiratory viral vaccines. As you can see, like influenza, this virus constantly mutates. Most mutations don't mean anything unless they're spike protein mutations that selectively affect its affinity for the binding site, you know, the domain. So as we keep giving vaccines, as somebody mentioned before, influenza, we keep on taking influenza vaccine, there may be some antibodies or some immunity that will protect us from new mutations. But we don't know yet with COVID what happened, but I have a feeling this will constantly mutate. There will be new mutations, and the vaccine efficacy will decrease in the future. However, there's a booster dose right now, the 3 weeks and 4 weeks. If you delay it or somebody misses, don't worry about it. Go there whenever you can and get the booster shot. You know, I don't know if that makes any sense.
No, Dr. Ramakrishna, I think you make sense. It is definitely. See, the whole studies were started and came up to be why it is 3 weeks, why is it 6 weeks. See, most of the immune system start producing the IgG antibodies with a peak after 3 weeks of the vaccination or the infection. So after that it persists, then they slow down because the memory cells are sitting there in the body, but they're not going to go away. So it may not be producing because there is no stimulus or there is no antigen there. So immune cells do not produce after 3 to 4 weeks. Slowly it will slow down over a period of time. But when they get exposed to another antigen, again, another repeat antigen, that cause all these memory cells that are sitting suddenly start rapid growth. That's where the booster dose comes in. That's where we developed about the booster dose. But the problem that we're seeing it is most of these studies we are just following about the antibodies and the antibodies and antibodies. We're not looking into all the other system. I think what we have to eventually come up, because it's a very short duration of the pandemic, we are rushing some guidelines we are following, we're setting up, and that I agree with that. But when the time passes on, you look into the population studies when you're seeing whether the infection rate, how they're coming in, gives you more data and the predictability of what you have to do and whether it is really needed a second dose or is it just one dose will give you a permanent immunity, or these memory cells reactivate whenever they get infection. All these data will come only on the population studies when you do over a large period of time.
So, Sudhakar, again, I'll go through the chat window questions. I'll answer one after the other. Can you give it, if you are on anticoagulants? So if you're on therapeutic dose, bear in mind that you're giving an intramuscular injection. It's not a subcutaneous. So there's a chance that you could have a minor bleed. But if you're on therapeutic levels of anticoagulants, you should not have a significant bleed. So it should be safe. But I think sometimes when you are on a combination of antiplatelet agents and anticoagulants at the same time, let's say you had a stent and therefore you're on multiple of drugs, then there's a chance that you may get a hematoma. So just watch it because you're giving intramuscular injection. Beyond that, I've not seen any major hematomas because you're using a narrow gauge needle. But just bear in mind, you're giving an intramuscular shot. The second question, will the PCR test become positive because you got a vaccine? No, you will not, because although you're giving a antigen which produces spike protein, it never reaches the airway. It's only the dendritic cells will pick it up in the interstitium of the shot itself. So you will never get that in the airway for the PCR to be positive. So it will not be positive. So tests will never be positive because of that. Can someone with psoriasis on methotrexate get the vaccine? Yes, they can, but be aware that if they do have a muted B cell response, so so when it was given with other vaccines, not COVID vaccines, when they gave vaccines to patients who are on methotrexate, the IgM response was very muted in them when tetanus toxoid and other vaccines were given. So you could also expect a muted response in psoriasis with methotrexate. Bear in mind, in the clinical trials, both with Moderna as well as AstraZeneca and Pfizer, they excluded all these patients in the clinical trial. So when you're giving in the real clinical world, you're gaining the experience, and we'd like to hear from you if you're seeing something that we have not heard of, because the clinical trial did not give us that information. So you have to give us that information. But it's safe to give, though. There's no contraindication from that. Suresh, anything you want to add?
Yeah, no, as I mentioned, also remember the PCR will not be positive because what we are doing is giving the protein or the mRNA, which is producing the protein. So that is what you're saying is that for the protein you're developing antibodies. So the PCR should not be positive. And the same thing with the mention about the autoimmune problems. Those who are on the immune suppressive drugs, you may not see the good response, as Sridhar mentioned, but there is no complications, no disease will occur with this problem. Only concern that I might have, again, it is a theoretical concern rather than seeing anything in studies, is if we know the concept of nets, that the neutrophil extracellular networks that we know, patients developing autoimmunity when this patient's having the COVID or other viral diseases. So whether this will trigger the autoimmunity by giving this vaccine, we do not know. So except that, I don't have any concern about giving these vaccines for these patients.
Yeah. Okay.
You know, can I add one thing?
Yeah,
somebody mentioning about neutralizing antibodies or antibodies and T cell immunity. What we know with viral infection vaccination is we are looking for neutralizing antibodies. That's what protects people. So if we go to a different scenario in rubella, for instance, a young nurse comes to work in a hospital, our serology for rubella antibody is very low, she will get a booster shot. You know, we don't depend on if she were to be exposed to rubella, her T cells will start producing, stimulating B cells and producing antibody. We still like to keep antibody at certain level by giving a booster at that time. That is what is current science is. I don't know how accurate that is, but that's what CDC and every educated people recommend to us. So we are looking at neutralizing antibodies and not depending on these viral infection T cell immunity, even though that comes in fungal diseases and TB and all that. So at some point, some kind of boosters are like in influenza case, always looking for new mutations and changing the vaccine very quickly, which we can do with mRNA vaccines. We can very quickly produce new strains, anti-new strain vaccines, and keep up in this game. So we only know about neutralizing antibodies protecting people. You know, we don't depend on T cell immunity, even though there is that immunity. You know, that this, how long this will last? Again, like influenza, probably not a long time if the virus constantly mutates. You know, the efficacy of vaccine, and hopefully the pandemic will be over. This will become an endemic disease like influenza, every seasonal or whatever, and not a major life-threatening disease for a large number of people. That's all. Thank you.
Yeah, thank you.
I agree, Ramakrishna. What you're saying is absolutely true. But unfortunately, the T cell immunity and the T cell importance of the T cell immunity to prevent the viral disease are only recent knowledge. It's in the last 10 to 15 years that is grown. We know more about viruses now than before. At the same time, even the whole T cell concept and T cell importance we know only since the AIDS came into the picture. So I think that now the most of the research are heading is to look into that. What is the importance of this T cell immunity and how long it is going to protect you? Is the reinfection is a variant of the virus, or is it because of we losing the T cell immunity, or is there any importance for the neutralizing antibodies? These are all the questions that we have to answer. Probably, maybe this disease, this pandemic, may be the one that triggers and get the answers for all these questions in the near future.
Excellent.
Yeah, thank you very much. And it's time to wind up this particular session. And before winding up, I wish to thank